Thank you very much. And thank you for inviting me. Thank you for giving me this opportunity. And my talk will be certainly relatively low tech as compared to several talks which were done yesterday. I have very few formulas. It will be rather a review of use of nuclear medicine, of Monte Carlo in nuclear medicine. So what is nuclear medicine first? Nuclear medicine, just a reminder, it's a use of unsealed radioactive compounds which are injected or inhaled or swallowed by patient in the diagnosis and also in treatment of diseases. So up to now, about 95% of nuclear medicine procedures doesn't work. 95% of diagnostic procedures, nuclear medicine procedures were diagnostics. Many of them, majority was imaging, some were not imaging, and therapy was only a small percentage of this. This is moving. Actually, those numbers are put just looking out in the sky. It's very difficult to say how much therapy, what percent of procedures is therapy, but it's getting more and more involved. Okay, so what is nuclear medicine? Nuclear medicine, the objective of nuclear medicine is to collect data. We use nuclear medicine camera, and this is for diagnostic imaging. And the very important information is to get the exact number of counts of photons, to measure the number of photons, to measure the position of events, the energy of the photon, and the time of detection. And of course, Monte Carlo needs to do modeling of all this. And this is what Monte Carlo role in nuclear medicine is. And actually where nuclear medicine uses simulations. First of all, to model, design and test nuclear medicine cameras and imaging systems. To understand data structure which we are collecting. To design quantitative correction and test reconstruction methods, to simulate internal dosimetry, including distribution of dose at the cellular level, also production of medical radioisotopes, observer performance studies where you simulate the data, you know the truth, and you try to assess the ability of the observers, and many, many others. I will not go through all these topics. I will go actually only at some of them to the simulation of internal dosimetry. So modeling of imaging systems. Well, those are some of the traditional systems for SPECT or SPECT-CT. So where the camera, 1, 2, 1, 2, 2 or more heads. Now we have majority of systems which have 2 heads. Some of them are CT, are rotating around the patient to collect data. Or it is PET, and those are some of the PET systems and PET-CT systems. We have also a lot of systems, is it too close? A lot of systems which have been recently introduced into the market, which are designed for cardiac imaging. This is IQ collimator. This is just a collimator which is focusing on the heart. Those are cardiac systems. This is cardiac, where the camera doesn't move, the patient is sitting in the chair, and actually a set of slits and holes is imaging the heart. The heart is positioned in the center. This is another system where actually the row of several CZT detectors with parallel collimators are actually flipping back and forth to get many angles of the imaging. And the last system is Discovery 530C. This is GE Healthcare, and actually the next talk will be about this system. All this system has been extensively, both traditional and this new system have been extensively tested by Monte Carlo. So, well, what is the role? To design the new cameras, and improve the old system, design and optimization of the new collimator. Parallel Hall collimator is used in SPECT probably 99% cases, but more and more people are trying to improve collimators, to use multi-pinhole collimators or other designs. Optimization of camera geometry, optimization of acquisition parameters, reconstruction, and so on and so on. And actually, for example, I will give some examples. Design of new system, a completely new idea would be a Compton camera, where you don't use collimator. This is so-called electronic collimation. You use this is the object, this is patient heart. The photon emitted from the object is assumed to be scattering in the first detector, which is a thin detector with high probability of Compton scatter. This is so-called scatterer. Then should be completely absorbed in the next detector. Of course, it doesn't happen always like that. But from the Compton formulas, you can reconstruct a conical surface from which this event should come. And now intersection of many cones provides the location for the source. And here are just examples from some papers where people are testing this system. This is a system which has several detectors actually, because scattering the first detector has only low probability. Here is another system where they try to measure, this is from Japan, they are trying to measure not only the energy, deposited energy of the electron, but also a direction of the electron, which gives much better localization of the event on the conical surface. Well, at every topic, I will try to tell you a little bit about MIRC, Medical Imaging Research Group, our group research. And actually, we have been investigating Compton camera, in particular, multiple coincidence Compton camera, where if you have an isotope, and actually there are quite a few of those, which decays through a series of lines, those lines will be creating a cascade of photons. They all should be recorded in coincidence. And actually, if you take the three strongest lines, you will have intersection of three cones. And the point of intersection should provide quite unique identification of the location of the source. So theoretically, it should be great. And we tried to investigate this hypothesis, and we did a lot of simulations using GATE. Actually, this is the ideal case where three cones coming from three events are intersecting in one spot. Unfortunately, in real case, this doesn't happen. This is a true intersection, but because of the limited resolution, energy, and spatial resolution of the detector, actually our event in reality is detected here. And it turns out that if you have single coincidence and you seek intersection of multiple cones, your resolution is better than when you detect triple coincidence, because actually, this idea doesn't work. There is a publication which refers to this. This is our publication. We are investigating the further step where you use a maximum likelihood method to improve the resolution and actually calculate better the position. The next step would be understanding data structure. Nuclear medicine, we are recording data. We want to understand what these data are. And the basic principle, basically, is Compton scatter. And this is a picture from the very old paper. If you measure spectrum in by nuclear medicine camera, you are just getting that total. But very often you want to identify primary photons and scattered photons. And basically only Monte Carlo allows us to identify not only primary, but also several orders of scatter, and will allow us to investigate how our correction method fits the true distribution of scatter. So basically, if we develop any method, we need to understand data structure. Again, about MIRC research in this area, we are moving to the very, very contemporary time. and actually this is about targeted radionuclide therapies. Well, the molecules labeled with radioisotopes are injected, and they're supposed to go to the patient, to the location of the tumor. And, well, the most popular isotopes are yttrium, lutetium, rhenium. They are all emitting beta particles. It will be very important to see where they went. And actually, based on imaging, we want to do dosimetry. I'll be talking about this a little bit later. Those are those three popular isotopes. There are many others, and actually alpha particles are also being used. Yttrium doesn't emit any gammas. Those others, rhenium and lutetium, they emit gammas, but actually those gammas, well, they are not very strong, first of all. And then there's a question, okay, if we have beta particles, so how much Bremsstrahlung do we have? Will we see this spectra? And even if we measure the spectra, we want to identify what is the background underneath the spectra. So we have, so how important is Bremsstrahlung? How much Bremsstrahlung we have? How to image this Bremsstrahlung? Where best to put energy windows? Actually, for each we have to image Bremsstrahlung, and how much it will contribute to the dose. And again, we have done some simulations using GATE, and this is yttrium for different collimators, and you can see that actually the shape of the spectra changes quite dramatically. And actually, this is a peak which we want to image. It's not very strong. You almost don't see it with this collimator, but if you use medium energy or high energy collimator, it's much stronger. Orange would be Bremsstrahlung. You see, we don't have Bremsstrahlung. Actually, Bremsstrahlung is much overwhelmed by the scatter. All this blue, this is scatter from high energy photons. It's interesting because those high energy photons, they have less than 1% probability of decay, but still they contribute so much because the collimator, especially low energy collimator, is transparent for them. And also, these low energy photons are better detected by our camera. On the other hand, for yttrium, we see that primary Bremsstrahlung, primary Bremsstrahlung is mostly here. This green peak is actually scattered in the collimator. Those are X-rays from lead. So this all allows us to investigate the spectra and to optimize conditions for imaging. So we see that Bremsstrahlung is important basically only for yttrium because we see only it in yttrium. And actually, this is mostly scattered Bremsstrahlung, so it will not provide us information about the location of the source, not direct information, or very poorly will provide this information. However, for rhenium and lutetium, Bremsstrahlung is basically not existent. Everything what we see is high energy photons, which are scattered. Okay, what about quantitative imaging? We need more and more, actually, people are stressing the need for quantitation. Everybody is talking about PET quantitation. SPECT is equally quantitative, and we can do quantitation. However, we need to investigate both quantitative corrections and reconstruction. So, for modeling our acquisition system and acquisition process, we need first to have patient. So we need to model the patient, and contrary to what was discussed yesterday, we are not only interested in the density distribution in the patient body, but also we are interested in activity distribution. We need to put different levels of activity, different regions of the patient. We combine this with CT or attenuation map to create a patient. Then we model SPECT or PET camera, and then we model physics of interactions. So, talking about patient, the first phantom which was created in 95 or even earlier, this was MCAT phantom. This was a geometrical model of the patient. The next generation, this is NCAT phantom. This is actually a series of primitives or shapes which are created with NURBS, and they are not voxelize, they are smooth, and you can fill them with different levels of activity or not activity, and combine them with attenuation. Recently, actually, maybe not that recently, the movement have been added. So actually, we have a beating heart, we have respiration. We can combine them all, and then you input activity and you model the patient. You have to model your imaging system to create data. You reconstruct data and you try to see how accurate you do. Additionally, there is, somebody mentioned yesterday, there is a similar model for a mouse. You can model a mouse, you can put different activities, you can put tumors inside, then you can acquire the data, and then this is simulated images, reconstructed images from the PET system. There is a large number of Monte Carlo programs which are specifically designed for nuclear medicine. They are modeling PET system or SPECT system or both of them, and actually recently probably the most popular system is a GATE program. Well, if anybody wants, I can give references, but they're easily found. Well, I said that we need to simulate to understand how the data are acquired and what are physical effects which contribute to our image and which destroy basically accuracy of our image. So this is a model of the patient. You have a heart, liver, kidneys, spleen. And now if you add, using Monte Carlo, actually this was modeled with CIMINT. This is another program which is specifically for SPECT. If you add respiration and heart beating, the image becomes blurry. Then you add resolution and potential patient movement. The scan is usually about 20 minutes, 15, 20 minutes. The patient can wiggle on the camera bed. Then there is photon attenuation, which removes some of the photons, especially from the central part of the body. Then you have scatter. Then you add noise. So you can see that the image, this is a projection image. This is what we acquire, is quite different from what we have here. So now we can investigate our corrections, how well they work, how well they do in removing all these elements. And you can, in particular, using Monte Carlo, you can, of course, isolate one or two effects. You can, of course, investigate different reconstruction methods. This is the most basic filter back projection. This is, again, a simulated project, a simulated object. This is actually a region, prostate region of the patient using different filters. This is the same object with attenuation correction, iterative reconstruction. This is attenuation correction and resolution recovery and different number of iterations and subset. You can investigate using this simulated data, different levels of noise in the simulated data, different levels of patient movement and other effects. You can investigate how well you're doing. You can do the same for brain. This is actually an example of brain study. You can see that few iterations result in a very, very smooth, over-smooth image. Then you improve, but if you iterate too much, you get, basically your reconstruction program starts to fit to the noise. Well, you can also simulate a dynamic heart. This is a rest study. Usually in nuclear medicine, we do two studies, rest in the patient, and we compare this with stress. In rest, usually the myocardium, if the patient is, even if the patient is sick, usually the myocardium is quite uniformly perfused. If you have stress study, all the arteries should dilate, but actually those which are sick or basically stuck with some plaque will not dilate as much. So actually you will see the differences in perfusion. And in particular, you can also check the movement of the heart, and well, you can simulate and check if your correction method works fine. So this is an example. I wanted also to tell you about milk research. those are our simulations. And well, we use this for development and testing of image quality, accuracy, and quantitation using standard methods, reconstruction methods. Of course, attenuation corrections. Actually, our group, we are very proud to say that we are the proud owner of one of the best quantitation methods for SPECT, the best in the world, probably. We investigate also image segmentation methods because those are very important for many applications. Partial volume effect corrections. I will not stop longer for this, but yeah. New reconstruction methods, and many, many others. And actually, I wanted to talk a little bit about completely novel method of image reconstruction. This is not based on Poisson statistics. This is something very new. So first, well, we created the data with GATE, and we did a simple back projection. So this is back projection of Compton camera. So this is one cone. And actually, this is intersection in the image space of one cone. This is one cone surface, 2, 3, 4, many. If you remove background, so this is what you get for the location of the source. We propose a completely different method, stochastic origin ensemble. Actually, this method was presented by Arek Sitek, who is an alumni of our group. And well, if you have those many, many cones, now we are not talking about simultaneous acquisition of a cascade of photons. This is just a regular Compton camera. So actually coming from detection of emissions from the source will be many, many cones. Let's say that we have source location here. Each cone corresponds to one measured event. And actually in this case, these 3 cones create an intersection of one event. So the first, in this new method, the first step is to identify cones. Then you distribute all events randomly on the corresponding cones. For every cone, there is a possibility of distributing. And actually, I'm not plotting many cones, but those will be many events. And then you identify their positions on the grid. Well, then you start moving this event. So you have an event, and you move the event randomly on the surface of each cone, because we know that this event is coming somewhere. Well, this cone corresponds to one event. And actually, we randomly assign one position. Now we are moving this position to a new position. And what are the rules? You select 2 states before the movement, after the movement, and you accept the new position only when there is a high density of previous events there. And actually, if the event is supposed to move away from high density, you rather reject this event. Of course, this is higher and lower probability. This is all based on the Markov chain probability. Eventually, quasi-equilibrium is achieved. And if somebody is interested, I recommend you read the paper when the mathematics of the whole method is described. It turns out that this method actually is way better, even in a not optimized version, than a standard maximum likelihood, especially for Compton camera. And actually, this is simple back projection. This is MLEM, and this is our method. And actually, well, don't be scared about this 1,000 iterations. Those iterations are not equivalent. Actually, they are much faster. So this is one of the examples of use. Well, the last topic which I want to talk about is internal therapy. Well, Monte Carlo is extensively used for external beam therapy. Actually, you cannot imagine treating a patient without performing personalized dosimetry. However, it is quite easy, well, from our perspective, it's easy to perform such dosimetry. You know the source of radiation. Radiation is present only over a short time. Energy is usually evenly distributed, high dose. In radionuclide therapy, you inject the activity and then you lose control. You don't know where it is. It can move through the patient, and actually it will move through the patient. And biokinetics of this movement can vary. So actually we need, for dosimetry, we need quantitative measure activity, we need quantitative imaging, we need, therefore, quantitative imaging technique, we need distribution of tissue density, and, well, we have low dose rates, actually. It is different calculation. No wonder that actually dosimetry in internal beam therapy is very rarely done. Majority of cases, patients just get one dose fit all therapy. Internal dose calculations are a little bit different. Well, the dose is the same everywhere. It's just energy deposited per unit mass. However, here we have a source and we have a target, and we need to know the injected activity. We need to know the time how this activity moves. We need to know the geometry of the target and source. Actually, the target can be the source. So this is our formula. This is cumulated activity integrated over time. This is type and energy of emitted particles, and this is absorbed fraction and the target mass. Well, this will be simplified. You can actually put everything in so-called S value. This is geometry of the patient and characteristics of the source. S value are usually expressed as dose per unit of cumulated activity. And actually, if you have several sources, you actually sum those contributions. I want to very briefly tell you about different models of those calculations. And Monte Carlo, again, is used everywhere. So first, it would be, and this method is quite actually popular, is so-called Olinda, organ level calculations. And actually, this is a reference, where this part you need to measure. This is characteristic for a patient. This will be for each organ. This is activity versus time. And this has been pre-calculated and stored for patient model. And there are several models. Everything started from a model which was like that. Actually, Olinda webpage claims that now we are using this model, which turns out not to be necessarily always true. So actually, this type calculations are still being used. Tumors are models are here. Everything is kind of predefined. This is not, Olinda type calculations are population dosimetry. This is not meant to be a dose for a given patient, because patient will look differently. The next level would be voxel as values, where you actually pre-calculate the dose from one voxel to the neighboring voxels for every given activity or isotope. This has been pre-calculated for many isotopes. Actually, there's one of the pages where those data are stored. And actually, many different voxel sizes are tabulated. This model assumes homogeneous tissue. This could be or tissue or soft tissue or bone, which actually works pretty well for the abdomen area. Those are also very fast calculations, and those can be much more modeled towards the patient. Again, this is based on Monte Carlo. And the last one is actually the completely image-based patient. We use patient CT images. We use nuclear medicine distribution of activity. We combine them using DOS XYZ or Penelope or other programs. The calculations are personalized, are the best, well, providing that we have accurate information activity distribution. They are very slow. We did, again, our research, we did extensive research on this area. We created a program which actually, JADA, which is now being commercialized by a company, UBC licenses to a company, which actually can do all this calculation. But we wanted to compare. So this is Olinda, this is voxel S value, this is image-based for 3 different tumors. And you can see that mean dose calculated by these 3 programs is very similar. So basically this will be the dose mean over certain organ. However, if you want to know the range of doses, those ranges are dramatically different well, there is a wide spread of ranges. Even within single tumor, the range of the dose can be very different. So absorbed dose calculation should be done using 3D, and actually Monte Carlo plays a very important role. I'm almost finished, just one more slide. Accurate co-registration is necessary for this 3D dosimetry because we need to know how the activity in a given region changes over time. So actually we acquire a series of images which we need to co-register. We don't need to segment those regions. Well, what is very important, we can use this approach for something which is a very modern concept, which is extremely appealing and very highly investigated theranostic approach, where the same molecule can be labeled with imaging agent, and when you diagnose the patient with this imaging agent, you identify tumor site and you identify kinetics of the molecule through the body, and then you can predict what will be the dose when you label the same molecule with therapeutic agent. Well, but we still don't know what is happening on the cellular level, and I really hope to learn something from a session which is here later, I think, today. So take home. Monte Carlo are extremely useful in many, many areas of nuclear medicine. They are used in research and also in clinical practice. Actually, all dosimetry is based on Monte Carlo. Monte Carlo gives us full control of the data. The model is always simplified. So if only possible, try to validate this. Thank you very much.
Any questions?
So a few years ago, I was told nuclear medicine physicians do not think dosimetry is very important. Has that been changed?
Well, nuclear medicine, radionuclide therapies are currently done based on the presumption that you should not inject patient with more activity than it is safe for critical organs, and the safe levels for critical organs are extracted, the information is extracted from external beam therapies. Therefore, patients are given very low dose. For some patients, it helps. For some patients, not so, because the dose is too low. The dose could be dramatically, by a factor of 2 or 3, increased if the personalized dosimetry is performed. For example, recently have been published a paper showing that limits from external beam therapy for kidneys, which is a critical dose for lutetium therapy for neuroendocrine tumors, is thought to be 27 grays. It turns out that in internal beam therapy, you can safely go to 40 grays. The characteristics of the dose is different. In external beam, you shoot the patient with very high dose, which disappears. Here, this dose is kind of dripping over long time. So actually, you can have some kind of recovery of some cells. So yes, personalized dosimetry is dramatically important. If the doctors are saying it's not important, it is based on the presumption that we are giving so little that we will not harm the patient. But at the same time, we are not curing those patients, or we are curing on very few of them, because you can agree that giving the same dose to the big patient, small patient with big tumor burden, small tumor burden is not the right approach.
Very nice talk. Thank you very much. You pointed to the answer to your previous question, the patient-specific needs for accurate dose calculations in medicine. So
I knew that those would be the most important part.
So it needs to be patient-specific. It needs to be made based on imaging data that you acquire on a specific patient, and I presume it also needs to be fast. So how? So calculation time 13 hours there. The order of days. So what's going to be the approach to make it fast?
Well, in internal beam therapy, everything, the time scale is a little bit different. You diagnose the patient, and actually what is really important, you need to calculate, you want to predict the dose based on some, using the theranostic approach, using on some diagnostic imaging agent, you want to predict what will be the dose for therapy. Actually, currently, there are very few such pairs, diagnostic and therapy, and they're not fully proven yet. You know, this research is only being started. So you image the patient, you can do this calculation. The patient won't be treated the next day. He or she will be probably treated in a few days. So you have safely time to do the calculations. Calculations actually voxelize. Calculations, we have recently published a paper, are very, very similar to personalized, completely personalized dosimetry. And they are way, way faster, except if between organs you have bone. Well, we identify that if you have a spinal cord between organ and tumor or something, then the dose will be off. We need full Monte Carlo, but actually voxelize is fine. So those calculations are very fast. So you can do those calculations, and then you invite the patient, you need to order the dose. It's a very different time scale. So we are not worrying for the moment about those calculation times. And well, of course, we want to do it fast, but it's much more important, you know, to define the protocols, to know how to measure, to know, well, you need to identify, usually, for example, for neuroendocrine tumors, the therapy is done in 4 up to 6 cycles. And there is no good predictor of the dose. So usually the first cycle can be used for dosimetry calculation for the next cycle and potentially prediction. But nobody is doing it yet. So for the moment, we are actually trying to apply for CIHR, which CIHR in general doesn't want to fund any nuclear medicine-based projects. But we want to apply basically to identify how we need to measure this, what times those time activity curves need to be measured to know how the activity moves in critical organs and in tumors. And then from this information, you can predict the dose for the next cycles and following. Thank you.